Good evening, our dear attendees, and good morning and good afternoon in different parts of the world. I'm Dr. Asma Jasser Benjab, pediatric endocrinologist at Sheikh Khalifa Medical City, Ajman. I'll be moderating this session, which is in collaboration between EDES and the American Diabetes Association, entitled as Type 1 Diabetes in the Modern Era, Prevention, Resistance, and Cardio Protection. This webinar is live streaming, so you can follow it as in your Zoom link, and plus later on, if needed, we can follow it on the YouTube channel as well. I kindly request you for all your question and answers for all 4 topics to be noted down in the chat box, and we'll answer it accordingly at the end of the presentations. And just to mention, this webinar is CME accredited. The detail will be sent to the registered attendees to obtain their CME credits 14 days after this webinar. I'll just go through some introductory remarks. So this is myself. I'm a consultant pediatric endocrinologist who did my training of pediatric training in Canada, and followed by my certification in pediatric endocrinology from McGill University in Canada. And I've been in the field of pediatric endocrinology currently for more than 15 years, and in the pediatric more than 25 years. Our first speaker for this webinar is our dear colleague, Dr. Walid Qablan, who is a consultant pediatric endocrinologist at the American Hospital in Dubai. He obtained his medical degree from Damascus University in Syria. He did his pediatric residency at Michigan University, followed by fellowship training at Baylor Medical College in States. And he's been serving in the field of pediatric endocrinology between USA and UAE for more than 30 years. And he is a very well-known speaker in the region and multiple conferences. He is recognized for his leadership in pediatric endocrinology across the Middle East. So Dr. Walid's topic is about prevention of type 1 diabetes mellitus. Dr. Walid, the floor is yours.
Thank you so much, Asma. Good evening, everybody. So it's my pleasure to be with you this evening, and I would like to thank the organizer for the kind invitation. I was asked to talk about update on the type 1 diabetes prevention, and my presentation will go over type 1 diabetes epidemiology, updated information, and then pathophysiology and the current definition of stages of type 1 diabetes. And then I will spend the most part of my presentation going over some of the important prevention trial of type 1 diabetes throughout the course of the disease. So as you may all know, type 1 diabetes affects 1 in 300 people in general population. But if there is one family affected, or one affected family member, the risk increases by 15 folds, reaching about 1 in 20. According to the IDF Atlas 2025, there is an estimation of more than 9 million type 1 diabetic patients worldwide, including the almost 1.4 million in the Middle East and North Africa. And as you can see that the subgroup of children or patients younger than 20 years is rather higher in our region compared to the different geographic areas. We all know that type 1 diabetes does have negative impact on lifespan, and this is reversely correlated with the onset of the disease. So the younger the patient, the more impact on the lifespan. But what this map is showing us, in addition to that, that there's also geographic differences in how much type 1 diabetes have significant impact on lifespan, such as Central Africa and the rest of the African continent being the most affected geographic place in the world, followed by South America and Asia, and then East Europe. And then we see the best outcome is in North America and Western Europe. So the pathophysiology of type 1 diabetes is multifactorial. So there is genetic predisposition presented in the form of specific HLA type and certain genes that have been linked to increased risk of type 1 diabetes. There are environmental factors associated with colder temperature and certain viruses. And there are also immune dysfunctions in the form of tolerance defect that have been contributing to the occurrence of type 1 diabetes. So this is the standard or the updated course of type 1 diabetes that has been changed from what we used to learn probably 10 or 15 years ago. So patients are born with the genetic predisposition, such as having a high-risk genes and HLA type. But then later on, they will have the immune activation. And there is still a lot to learn about this particular part of the course of what are the exact triggers of the immune activation. We're learning about this. But what we know that once the activation starts, the T lymphocyte starts attacking the beta cells in the pancreas, which will lead later on to reduction in the mass or percentage of functioning beta cells. So there are 3 stages of type 1 diabetes. In stage 1, patients are known to have 2 or more positive antibodies, minimal loss of beta cells, and they will be normal glycemic at this stage. In stage 2, patients continue to have the positive autoantibody status. They would lose more beta cells and they will have dysglycemia, as would be diagnosed from the OGTT or HbA1c, but they will not have clinical symptoms until they reach stage 3, where they would be lost or losing substantial percentage of beta cells, and they will have the typical symptoms of diabetes, and the clinical diagnosis is made in stage 3. You might see in other slides or cartoon stage 4, indicating the well-established type 1 diabetes. So the pharmacological agents that have been used in the different trial for diabetes prevention have been targeting different aspects of the autoimmune process. So either directing toward depleting beta cells that are considered a powerful antigen-presenting cells in type 1 diabetes, or antagonizing the cytokines that results from the T lymphocytes attack to beta cells, or they might actually use the agent that directly targeting T cells. Alternatively, some agents have been used that are blocking the chain of activities that lead to T cell activation, such as the anti-CD3 monoclonal antibodies. And finally, using agents like abatacept, which disrupt the T cell co-stimulation signaling. So each one of those factors have been used in different studies with the justification of blocking the final outcome of active T lymphocytes that have been resulting in attacking and destroying beta cells. In a timely way, if we need to classify the prevention trial, we can classify them into primary prevention that aims to stop or prevent, actually block the immune activation, or secondary prevention that aim to delay the onset of type 1 diabetes, or a tertiary prevention, which is in fact not a prevention because they basically they're done after the diagnosis of type 1 diabetes, but they aim to preserve beta cells and modify the course of the clinical disease of diabetes. Because I have only 20 minutes, as you can tell, it will be quite difficult to go through all these studies, but I would like to give you a summary of what those studies have been showing so far. So for the primary prevention, unfortunately, as of today, there is no therapy that has been successful to prevent type 1 diabetes in the general at-risk population, but oral insulin in particular has been showing promising results in specific subgroups of patients, as I will explain later. And the secondary prevention, teplizumab, is the only treatment that has shown benefit in delaying the onset of type 1 diabetes and has been approved to be used in clinical practice for that purpose. And for the tertiary prevention, basically, there are multiple agents that have been used and show benefit in preserving beta cell functions, but to some extent. And I will not be able to present again all the studies in all these different phases or stages. So I'm gonna focus mainly on the oral insulin trial. And we have 3 studies to present: the diabetes prevention trial, number 1, and the trial NET-07, and the primary oral insulin trial. For the teplizumab, I'm going to present the 2 studies, that one for the trial NET-01 and the other study from the PROTECT project. So starting with the oral insulin, the main idea of using oral insulin as an agent for preventing type 1 diabetes is to desensitize the immune system to the antigenic effect of insulin in those patients. So one of the earlier studies was done 20 years ago. In that study, they have randomized 372 relatives of people with type 1 diabetes who also have positive antibodies into either oral insulin or placebo. The primary outcome was diagnosis of diabetes, and the median follow-up was 4.3 years. And that study did not show any effect in delaying the progression to type 1 diabetes in the insulin arm compared to the placebo. However, there was a subgroup of patients with high insulin antibody titer that actually showed benefit with annualized diabetes rate of 6.2 in the insulin arm compared to 10.4 in the placebo arm, and that was statistically significant. After that studies, patients with positive antibodies, including high insulin autoantibodies, were enrolled in other trials, such as this important study of TN07, where patients, almost 560 patients, were randomized into, again, oral insulin, 7.5 milligram, or placebo, with a median follow-up of 2.7 years. Primary outcome is time to stage 3 diabetes. This cohort was also further subclassified into 4 subtitles according to the first phase of insulin response, or the type of antibodies. And the outcome showed, in overall, no significant delay in progression to type 1 diabetes. However, the subgroup with the low first phase insulin response did show significant delay in insulin or diabetes start compared in the insulin arm compared to the placebo arm. The same cohort was revisited in 2024, and patients were evaluated in terms of specific HLA classes and the antibody status, and they did a post hoc analysis to quantify the preventive efficacy of oral insulin in those subgroups. And they found actually that oral insulin did reduce the frequency of type 1 diabetes in participants with high IA2 antibodies, but did not show any preventive effect in those participants with low IA2 antibodies. And they found correlation between the IA2 antibodies high level and the HLA, DR4, and DQ8. So in their conclusion for that study, that oral insulin delays the clinical type 1 onset in the presence of HLA-DR4DQ8 and or elevated IA2 level of antibodies in participants with stage 1 or stage 2 type 1 diabetes. The most recent study of using oral insulin was published in Lancet just a few days ago. And in that study, they have enrolled infants between 4 and 7 months of age with a specific HLA and either a high genetic score for type 1 diabetes or having a first-degree relative of type 1 diabetes. This cohort was randomized into either a placebo or insulin, but in this time they did not stop at the low dose. They have increased the dose from 7.5 milligram to 67.5 milligram over 4 months period. Patients were maintained on this for 3 years, and they were followed for another 3 years, and there were more than 500 subjects in each arm of the studies. The primary outcome was the detection of 2 or more antibodies. Secondary outcome was the diagnosis of dysglycemia or diabetes mellitus. So what they found again is that oral insulin overall failed to reduce the incidence of islet autoantibodies compared to placebo. However, they found that participants who developed the primary outcome to have the positive antibodies, in those participants, the 3 years diabetes-free survival rate was 63% in the insulin arm compared to 35% in the placebo arm, and that was statistically significant. Furthermore, they found a positive correlation between the treatment outcome and the insulin genotype. So for the primary outcome, they found that insulin actually increased the occurrence of positive antibodies by more than twofold compared to placebo in the participant with the type 1 diabetes non-susceptible insulin gene, whereas for the secondary outcome, the same intervention, that is insulin, decreased the dysglycemia or diabetes by more than 60% in participants with type 1 diabetes susceptible insulin genes. So this is the figure showing the cumulative incidence to positive antibody. The red line is the insulin arm, the blue line is the placebo, and those were the type 1 diabetes non-susceptible insulin genes. And this is the risk of having dysglycemia or type 1 diabetes. And this is the insulin arm, and this is the placebo arm, but that was in the participant with the susceptible insulin genes. Moving now to the teplizumab trials. There are 2 trials. One was published in the New England in 2019. In that study, subjects between the age of 8 and 45 years of age who have stage 2 type 1 diabetes and have positive family history of diabetes in relative were randomized into either teplizumab or placebo. Again, teplizumab was given in escalating doses, and patients were followed to look for the primary outcome, which is time to diagnose diabetes in both groups. And as you can see, this is the median age of having type 1 diabetes in the placebo group, which was 24 months for 50% to have diabetes, compared to 48 months in the teplizumab group, which resulted in 2 years delay in the onset of stage 3 type 1 diabetes. In the extension trial that looked for those patients for an additional year, the delay in type 1 diabetes was extended to 2.7 years. The main side effect of teplizumab was lymphopenia, but it was transient, and it corrected after 7 weeks or 6 weeks. As a result of this study, teplizumab got the FDA approval to be used to delay the onset of type 1 diabetes in patients 8 years and older who have stage 2 diabetes and positive family history of type 1 diabetes. Recently, teplizumab was also used in newly diagnosed type 1 diabetes. This time they have looked in patients who were diagnosed within the previous 6 weeks between the age of 8 and 17 and who had at least one positive antibody and stimulated C-peptide of at least 0.2 picomole per ml. Those patients, 217, were randomized in a ratio of 2:1 between teplizumab, given 2 courses, each course for 12 days, 26 weeks apart, or placebo. The primary outcome was the C-peptide change from baseline to weeks 78. The secondary outcome was insulin dose to meet glycemic goal and time in range. So as you can see in the first result, that the area under the curve for C-peptide was higher in the teplizumab group by 60% compared to the placebo. And they found that 95% of patients who were given teplizumab had a C-peptide of at least 0.2 picomole per ml, which is considered clinically meaningful level compared to 79% in the placebo group. As for the insulin requirement to maintain glucose or target glucose and time in range and HbA1c, there was no difference between teplizumab and placebo. So in their conclusion, teplizumab given for 2 courses maintained beta cell functions. However, it did not result in significant difference in relation to the secondary endpoints. So in summary, type 1 diabetes is a lifelong autoimmune disease that affects children, adolescents, and adults. It is characterized by 3 stages of progressive T-cell mediated damage to beta cells that lead to loss of glycemic control. Preventive studies have been directed toward either preventing the autoimmune activation or delaying the onset of type 1 diabetes or preserving beta cell mass and function after the onset of type 1 diabetes. There has been some partial success in specific subgroups of patients in the form of delaying the onset of type 1 diabetes or preserving beta cells. However, not much success in preventing the autoimmune activation. Thank you very much.
Thank you, Dr. Walid, for your presentation. And now we'll be moving to the second presentation of this webinar, which will be, can you have this slide, please? Which will be presented by Professor Janet Snell-Bergen, who's a professor of pediatrics and epidemiology at University of Colorado. She's a director of clinical epidemiology at Barbara Davis Center of Diabetes, and she has a PhD in epidemiology from University of Colorado and MPH from Columbia University. She has more than 20 years experience of research in type 1 diabetes complication and cardiovascular risk, and she's been a principal investigator for NIH and ADA funded studies on diabetes outcomes and has published extensively more than 150 peer-reviewed papers with highly indexed over 60. She has great expertise in the CGM metrics, automated insulin delivery, and the kidney metabolism, and a global thoughts leader advancing diabetes research and monitoring future clinicians. She will be presenting about insulin resistance in type 1 diabetes mellitus. Dr. Janet, you can start your presentation.
Thank you very much for the kind introduction. Let me go ahead and share. So metabolic dysfunction in people with type 1 diabetes is mainly thought of as hyperglycemia. And this is due to insufficient pancreatic insulin production as a result of beta cell destruction, as you just heard in the previous talk. In contrast to type 2 diabetes, where insulin resistance plays a greater role in the etiology of diabetes. But treatment of type 1 diabetes is mainly by insulin, either through multiple daily injections or insulin pump infusion. And this treatment requires supraphysiologic doses of insulin in order to have high enough systemic circulation to achieve glycemic control. And the injection or infusion of insulin in subcutaneous tissue results in lower insulin levels in the liver as it avoids the first pass effect of insulin, where normally at least half of insulin is cleared by the liver as it passes through the portal circulation. So insulin resistance is actually common in people with type 1 diabetes, partly due to the exogenous insulin treatment. So what is insulin resistance? So insulin is a hormone that's secreted from the pancreas into the portal circulation in people without type 1 diabetes, and it impacts glucose homeostasis through effects in the liver, adipose tissue, and muscle. So in the liver, insulin decreases the production of glucose and promotes glycogen synthesis, and in adipose tissue, insulin promotes the storage of triglycerides and suppresses the release of free fatty acids. In muscle, insulin promotes uptake of glucose and amino acids and also increases protein synthesis and storage. So when insulin action is impaired in the various tissues, then there's impaired suppression of hepatic gluconeogenesis, which increases blood glucose levels. In the adipose tissue, insulin resistance causes excess release of free fatty acids and chronic low-grade inflammation. And in the muscle, impaired insulin action decreases the uptake of nutrients, and this leads to higher blood glucose because less of the glucose is brought into the skeletal muscle, which is one of the main users of glucose. And there's also decreased muscle glycogen synthesis and altered fat metabolism. While insulin deficiency is the most obvious cause of type 1 diabetes, insulin resistance has also been noted in a variety of studies across different age groups. So even children with type 1 diabetes have been found to be more insulin resistant. And this insulin resistance may play a role in the progression to symptomatic type 1 diabetes among islet autoantibody positive first and secondary relatives of people with type 1 diabetes as well. So it's been shown in various studies that short-term hyperglycemia can induce insulin resistance, decreasing whole body glucose disposal by more than a quarter. But whole body and tissue-specific adipose and liver insulin resistance have been found even when people meet glycemic targets. So what are some of the causes of insulin resistance in type 1 diabetes? So as I just mentioned, chronic hyperglycemia can lead to glucose toxicity, and damage to cells can make them less sensitive to insulin. Also, the exogenous insulin use leads to peripheral hyperinsulinemia, and these higher levels of insulin can make cells less sensitive. Obesity is also increasing in people with type 1 diabetes, especially with more intensive insulin therapy. And chronic inflammation associated with having diabetes can lead to impaired insulin signaling. There's also an increase in oxidative stress in people with type 1 diabetes, and there can also be an underlying genetic risk. So people who have a family history of type 2 diabetes or have specific genes associated with insulin resistance can have an increase in the risk of insulin resistance. And there are also conditions associated with insulin resistance, including polycystic ovary syndrome, that are more common, for example, in women with type 1 diabetes. So I'm going to tell you today about some of our studies looking at insulin resistance using the gold standard method for measuring insulin resistance, the hyperinsulinemic euglycemic clamp study. In this study method, we infuse a set amount of insulin calculated per meter squared of body surface area, and then we use a variable glucose infusion rate to achieve a target euglycemic level of blood glucose. So in our studies, we use tracers to look at glucose rate of appearance and rate of disappearance. And so we have a tracer infusion for 2 hours prior to beginning the clamp study itself. Then we perform a hyperinsulinemic euglycemic clamp, typically in 3 stages, targeting adipose tissue with a lower dose of insulin starting at 4 milliunits per meter squared per minute. And then a second stage targeting liver at 8 milliunits per meter squared per minute of insulin. And then finally, we do a whole body or muscle insulin sensitivity stage with a higher dose of insulin at 40 milliunits per meter squared per minute. And we use a target of 90 milligrams per deciliter for euglycemia. So again, we're targeting adipose tissue. We look at free fatty acid reduction. We also use the tracers to look at rate of appearance of the free fatty acids. For the liver, we look at the rate of appearance of glucose. And then for the muscle, we look at glucose infusion rate, which is an estimate of insulin sensitivity, looking at the amount of glucose that we need to infuse to keep people at the 90 milligrams per deciliter. And then we can also use tracers to look at rate of disappearance. So one of the first clamp studies that we did was in the coronary artery calcification in type 1 diabetes study. So we examined insulin sensitivity in a group of men and women with and without type 1 diabetes. So shown here are the baseline characteristics. On average, people were in their mid-40s. And among those with diabetes, excuse me, they had about 30 years of duration. We did limit A1C to those who had A1C less than 9.5 to avoid the glucose toxicity above those levels. And body mass index in our cohort was pretty similar by diabetes status, with about 28 and 27 in men and a BMI of about 26 in women. And as shown here, the lipid levels, so fasting cholesterol and triglycerides, were lower in people with type 1 diabetes, as well as LDL cholesterol. There were no differences in HDL cholesterol and no differences in blood pressure. So shown here is the estimate of skeletal muscle insulin sensitivity using the glucose infusion rate. So again, we were keeping insulin at a set level at a high dose during this third stage of the clamp, and then looking at the glucose infusion rate during the last 30 minutes averaged together. And that gives us an idea of how much glucose is being disposed. So as you can see, the glucose infusion rate was lower in women with type 1 diabetes than control women. It was also lower in men with type 1 diabetes compared to men without diabetes. But there was a greater decrease in glucose infusion rate among women when they had diabetes. So then we used tracers to look at the glucose rate of disappearance. So shown here with the stages, stage 0 is during the tracer infusion, stage 1 and 2 are those lower dose infusions. So stage 3 is where we were targeting the muscle insulin sensitivity. And you can see that the highest glucose rate of disappearance, meaning the greater amount of glucose that was brought into the skeletal muscle, was in the women without diabetes, shown in the yellow bar, and followed by the men without diabetes, and then men and women with type 1 diabetes both had impaired glucose rate of disappearance. Next, we looked at hepatic insulin resistance, looking at the glucose rate of appearance. So again, insulin should suppress the gluconeogenesis in the liver. And as shown here, there were also significant differences with suppressed glucose rate of appearance in people without diabetes, but less of this suppression among both men and women with type 1 diabetes. And finally, in the adipose tissue, we looked at release of free fatty acids. And then we also looked at free fatty acid rate of appearance and then glycerol rate of appearance. So free fatty acids in stage 0 was during the infusion of the tracers. Stage 1, free fatty acids actually went up in some of the groups and then were suppressed in stage 2, and finally came together among all of the groups in stage 3 with such a high dose of insulin. So again, we were targeting suppressing free fatty acid release in stage 1 with that lower dose of insulin. And you can see that there's a large difference by diabetes status. So similarly, with free fatty acid rate of appearance using the tracer data, we saw that the free fatty acids were suppressed in people without diabetes to a greater extent than both men and women with type 1 diabetes across all of the stages. And then finally at stage 3, everyone's free fatty acid rate of appearance was suppressed. So in the study that I just showed you from the cacti study, we included older adults. Many of them were on statin medications among the participants with type 1 diabetes, and many of them were obese. And so we wanted to isolate the effect of just type 1 diabetes in non-obese adults who were younger. And so we performed a study looking at the tissue-specific phenotype of insulin resistance in type 1 diabetes, and we included 50 adults. 27 with type 1 diabetes, and 23 without diabetes. Participants were non-obese, between 20 and 45 years of age, non-smokers, and not taking statin medications or oral anti-diabetic medications. So again, we performed hyperinsulinemic euglycemic clamp studies to measure whole body insulin sensitivity. So shown here are the baseline characteristics of this group. So their ages were quite a bit younger than the previous study that we performed, with an average age of 25 in men with type 1 diabetes and 31 in non-diabetic men, and about 30 and 31 in women. The cohort had similar body mass index across sex and diabetes group, but women with type 1 diabetes had slightly higher body fat than non-diabetic women. Again, lipids were more favorable in both men and women with type 1 diabetes, as in the previous group. And in this study, we added some additional measurements. We measured insulin-like growth factor, or IGF-1, which was lower in women with versus without type 1 diabetes, but no differences in IGF binding protein 3. And glucagon was lower in type 1 diabetic versus non-diabetic men. And there were diabetes by sex interactions for triglycerides and glucagon, which were significantly lower in type 1 versus non-diabetic men, and IGF-1 was lower, and human growth hormone was higher overall among adults with type 1 diabetes versus the non-diabetic control group. So shown here is the skeletal muscle insulin resistance estimated using the glucose infusion rate. So again, the higher the glucose infusion rate, the more insulin sensitive. So you can see that both men and women with type 1 diabetes had similar glucose infusion rates and much lower than the men and women without diabetes. And interestingly, as I mentioned, glucose toxicity at high levels of hemoglobin A1C can be present, but we did not see an association between hemoglobin A1C and insulin sensitivity tertile within either the type 1 diabetic or the non-diabetic group, which of course they were not even pre-diabetic. So the third study that we conducted, looking at the previous studies showing sex differences where women seem to be more affected by insulin resistance than men when they have type 1 diabetes, we decided to look more in depth at some of the factors that may be specific to women. So the objective of the WISH study, Women, Insulin, and Sex Hormones, was to examine what risk factors, including sex hormone concentrations, may contribute to this increased insulin resistance. So we included premenopausal women, 18 to 45 years of age, and they had to have regular menstrual cycles so that we could track their hormones across the menstrual cycle. So we included 12 women with type 1 diabetes with at least 5 years of diabetes duration, and again, hemoglobin A1C less than 9.5%. And 13 women without diabetes were included. So shown here are the baseline characteristics. Again, the average age in these groups was 36 and 30 for the type 1 women and the controls, with about 21 years of duration of diabetes. So hemoglobin A1C on average was 7.1, so relatively good control. And the fasting glucose and fasting insulin, as expected, were higher in the women with type 1 diabetes. There was also a higher body mass index, waist circumference, and also higher fat-free mass among women with type 1 diabetes. But as in previous studies, triglycerides were lower. There was also much lower vigorous physical activity reported by women with type 1 diabetes. So shown here is the glucose infusion rate per fat-free mass, per kilogram of fat-free mass. So again, women with type 1 diabetes have much lower glucose infusion rate than women without diabetes, about a third of the level. And also we found, as in the previous study, that free fatty acids during the clamp were actually increased in stage 1 when we had that lower dose of insulin. So it was actually less insulin than people were taking normally. And then it decreased in stage 2, but it was impaired in women with type 1 diabetes, the suppression of free fatty acids. So next we looked at sex hormones by diabetes status across the menstrual cycle, and we found that women with type 1 diabetes had significantly higher sex hormone binding globulin across all phases of the menstrual cycle. And again, sex hormone binding globulin is produced in the liver, and so this may be due to lower levels of insulin reaching the liver. Testosterone concentration was higher in women with type 1 diabetes than controls during the early follicular phase. And again, these were women with normal regular menstrual cycles. And so we probably didn't have any women with polycystic ovary syndrome in this study, but nevertheless, the testosterone was increased. We didn't see any differences in estradiol or estimated free estradiol or free androgen index. And differences in glucose infusion rate by diabetes status were partially explained when we adjusted for waist circumference, vigorous physical activity, free estradiol, and total testosterone. So looking at these 3 studies together, I'm showing here the combined characteristics of all 3 of the studies here. So our hemoglobin A1C, again, on average altogether was 7.2 in men and 7.1 in women. And we had lower levels of total and LDL cholesterol and triglycerides, particularly in men when they had type 1 diabetes. So shown here are the 3 studies with the skeletal muscle insulin sensitivity as estimated by the glucose infusion rate. So you can see they're similar across studies with a greater effect in women than in men. So one of the questions is insulin sensitivity normal in people with type 1 diabetes who achieve glycemic targets? So we looked at the glucose infusion rate in people without diabetes compared to strata by A1C. So in people who had an A1C at goal, less than 7%, there was still a much lower glucose infusion rate showing greater insulin resistance. This was particularly true in women, whereas in men there was not a significant difference for the A1C achieved less than 7%. But overall, there wasn't a large effect of A1C strata on glucose infusion rate. So insulin resistance is particularly important because it seems to contribute to cardiovascular disease in type 1 diabetes. So the glucose infusion rate that we measured in the first study in the cacti cohort was actually correlated to the amount of coronary artery calcium, which is a measure of subclinical atherosclerosis. So it appears that insulin resistance is still related to the same factors as in people without diabetes. For example, triglycerides and body mass index were correlated with the glucose infusion rate. But in people with type 1 diabetes, they're much more insulin resistant at the same level of triglycerides and at the same body mass index. So we developed an equation to estimate insulin resistance in people with type 1 diabetes because performing hyperinsulinemic euglycemic clamps is very time-consuming and expensive. So we developed this equation that included waist circumference, insulin dose, adiponectin, triglycerides, and diastolic blood pressure. And we've published this equation, and we performed a comparison of this prediction equation compared to some of the other published insulin sensitivity equations, and found that it performed very well across various different clamp studies, including in the WISH study that I also talked about today, as well as in some adolescent studies. So in summary, insulin resistance in liver, fat, and muscle are increased in adults with type 1 diabetes, even in the absence of obesity. And insulin resistance associated with type 1 diabetes may impact women more than men. Very high hemoglobin A1C may increase insulin resistance, but there appears to be no relationship between A1C less than about 9% and insulin resistance. And greater insulin sensitivity is predictive of lower cardiovascular risk in adults with type 1 diabetes. And I'd like to acknowledge the co-authors and study staff and students and trainees and support for these studies. Thank you.
Thank you, Professor Janet, for your great presentation. And we'll be moving to the third presentation of the day, which will be presented by Dr. Nando Thalangate. Dr. Nando is a colleague and he's a consultant pediatric endocrinologist at Genesis Healthcare Center in Dubai. Previously, he was a consultant endocrinologist at Al Jalila Children's Hospital. Dr. Nando obtained his degree from King's College in London, and he has served as a consultant at Norfolk Norwich University Hospital and also in Manchester. He led the global clinical trials as a chief investigator for Levemir and Tresiba in children, and introduced the AI-driven bone age analysis, genetic diagnostics, obesity, and lipid therapies in UAE. He's currently also as a clinical professor at Mohammed bin Rashid Medical College in Dubai. The topic of Dr. Nando will be about the adjunct therapies in insulin resistance in type 1 diabetes. Dr. Nando, you can start, please.
I'll just share my slides. I hope that I'm sharing my slide. I can't tell, to be honest.
No, we can't see the slides yet. Yep.
So,
can you do the screen, maybe full screen?
there. So, well, thank you very much for everyone who's here, and I hope I can keep your interest in the next 20 minutes. So, insulin resistance, as you've just heard eloquently from Prof. Janet, has many factors that contribute to it. So one is the genetic predisposition. We know that it's worse in families with a history of type 2 diabetes, for example. It's worse if you're obese or if you have a sedentary lifestyle. There are obviously the pubertal changes, which are more marked in girls than boys, and chronic hyperglycemia, again, as Prof. Janet has already told you. And it results in increased insulin requirements with poor glycemic control, despite having, I say, adequate insulin therapy. It's, despite high doses, you may not actually achieve your level of control. And weight gain also results from those escalating insulin doses. And again, as Prof. Janet showed us, accelerated risk of cardiovascular disease and renal disease. So we have some potential challenges here. What do we do about it? So what are our options? Well, there's diet and lifestyle. We know that in general, encouraging people to do diet and lifestyle is a good thing, but in practice, it's often not successful as a strategy, certainly not as a long-term strategy. Metformin is often used and tends to be considered as first line. And there has been a lot of recent research focusing on the use of GLP-1 analogs and to a lesser extent SGLT inhibitors. And there are some historical therapies. Pioglitazone was used in the past, but really there are better and safer alternatives if you're going to go for oral therapy now. And pramlintide, an amylin analog, amylin's a hormone also made in the beta cell. It's an effective but onerous treatment requiring a separate injection, and anyway, it's no longer available. But there are long-acting amylin analogs in development, such as cagrilintide, which may in the future come to the market. So I'm going to dive into some cases. So Fatima, type 1 diabetes for 7 years. She's obese. She has a high HbA1c, a high insulin dose. She's on the G7 and MDI with insulin degludec and ultra-rapid insulin lispro, so early, I will call it. And glycemic control remains with progressive weight gain and further worsening insulin resistance. So we added metformin, as is the sort of standard advice, and dietary counseling and exercise recommendations, and insulin adjustment. Obviously, we have to keep optimizing the insulin to try and maintain control, but the outcomes were not good. At 6 months, her HbA1c hardly fell at all, her total daily dose hardly fell, she was getting side effects. Initially, she stuck to the treatment, but then the adherence declined because she perceived no benefit, really. And that is the typical story of my metformin patients, that they just don't see that it's doing much. So what can we do? Well, given that she was obese, and obesity is an approved indication for semaglutide over the age of 12, we suggested this approach, and she was initiated at the starting dose of 0.25 and titrated up over the next few months. And we know that semaglutide is very effective for weight reduction and glycemic improvement. And how did she do? Well, actually, she did rather well. She had an 8-kilo reduction in weight. Her BMI reduced from 32 to 28. HbA1c improved, although still higher than we like. And total daily insulin reduced markedly, with an improvement, significant improvement in time in range. Again, still not quite there, but not too bad, all things considered. So we have done a study in Al Jalila Children's Hospital, my old hospital, looking at the use of semaglutide. We had a small cohort of 22 adolescents treated with semaglutide, and we saw highly significant improvements in HbA1c, weight, and insulin requirement. And over 80% of patients responded with either a fall in HbA1c or a fall in weight of over 5%, or both, although there were some, as always in any study, there are always some non-responders. So that's a manuscript in preparation, so hopefully that will be published next year. So on to our next case. So we have Omar, who's a 17-year-old boy of Indian origin. So we know that people from the Indian subcontinent are particularly insulin resistant anyway, so there's the genetic predisposition as well as the type 1 diabetes. His A1C is actually rather good, but the price of him maintaining that A1C has been a lot of weight gain, and his BMI is going up quite rapidly. He's on MDI and CGM. He had a pump early on after diagnosis, but he stopped it, I suppose adolescent rebellion, and won't consider it again. He is frustrated by his weight gain, but on the other hand, he's not keen to have what he regards as more objectionable therapy. And in particular, he wasn't keen on starting semaglutide. So we started dapagliflozin. Now, you might question that, but anyway, we did, because it improves insulin-independent glucose disposal, improves A1C, and attenuates weight gain, and has proven efficacy in adolescent type 1 diabetes. But of course, there is an increased risk of DKA. So when you do this, if you do this, then you have to do a lot of education to mitigate that risk. This was evaluated recently in this paper from Nature Medicine in the ATTEMPT trial, a study of 98 adolescents, 12 to 21, and they were given either dapagliflozin or placebo. And there was a almost half percentage point reduction in A1C, a small weight loss of almost 3 kilos, and an improvement in time in range of 9%. And there was one mild case of DKA in the active treatment arm. So it can be done relatively safely. So one of the reasons we considered it in Omar was because he was well controlled. So he's adherent to therapy, and that's important. If you're on a long-acting basal insulin like Tresiba, it's going to protect you from ketosis. Here you see his before and after CGM profiles, and you'll see this beautiful response with, as expected, the SGLT2 inhibitor just creaming off those postprandial peaks. So they are there, but they're much lower, and his control improved. So he was generally happy with his improved control and weight stabilization. He had no DKA episodes. His weight, so he had been gaining weight inexorably, and he lost 2 kilos. So he was very happy with that weight loss, and at least it's not getting worse anymore. And his HbA1c was no better, but his bolus insulin dose reduced by 20%, indicating that his insulin sensitivity has increased, although whether Prof. Janet would call it increased insulin sensitivity, I will let her tell me afterwards. So I think that in selected cases, SGLT2 inhibitor therapy can be safe and effective. Obviously, I forget which company it is that makes sotagliflozin, but they've been fighting that battle with the FDA for years and not succeeding. But maybe with the advent of ketone monitors, cutaneous continuous ketone monitors, we will have an answer for those worries. Now here we have Layla, type 1 diabetes for 6 years, HbA1c 8.1%. She's obese, so 28.3 is in the obese range for a 12-year-old. And her weight issues really started in puberty, which is such a common thing that I see. And particularly with significant duration of diabetes, we also see rising blood pressure and the emergence of microalbuminuria. So it's a tricky time, because if you lose control in this period, you really compromise the long-term prognosis. Now, she was on the Omnipod pump, which in principle she was happy with, but unfortunately her dose, a total daily dose of around 80 units a day, meant that her pods were not lasting the full 3 days, and this insurance wouldn't cover this. So it was expensive for the family to pay for 50% more pods, and it was inconvenient because the pod would fail at inopportune times, and or run out of insulin at inopportune times, and it would cause her problems. And basically, parents and Layla herself wanted a better answer. So what I often will do in the situation of a pump not lasting sufficiently long, and there are various situations when I might do it, is to start some degludec, basically enough degludec to allow the pods to last, and this will take away this degludec insulin from the basal insulin on the pump. But we also, in Layla's case, wanted to improve her insulin sensitivity, so we advised her to have combination therapy with liraglutide, which does come as a combination injection. So although she's now got to have an injection as well as her pump, it's only one injection. It's not 2 separate injections, although that would be an alternative if you didn't have access to the combination treatment. And both elements, degludec and liraglutide, are approved at this age, so I don't regard that as an issue in terms of approval. So she started on 16 units daily, adjusting her insulin doses accordingly, and titrated up to 30 units based on her glucose response. And she's doing very well. So her insulin dose went down from a baseline of 75 units a day at the moment we started to 35 units a day, albeit that she's having 30 units a day of Ideglira. So it's not that she's, gone down to 35 in total. She also managed to lose weight and her A1C improved. So I think, there's not so many treatments that will do all of those at once. And I think it was a good choice for her, and she's very happy with it. So improved treatment or improvement, satisfaction with treatment and quality of life. And the patient, she was thinking that she ought to stop her Omnipod, and now she's going to carry on. And I think that's a very good decision for her. Her hypoglycemia did not increase, and she's obviously not having to pay for extra pods anymore. She does have nausea, but one of the interesting things about Ideglira is it tends to have much less nausea associated with it, provided you titrate up from a lower dose, which is what we did. So, and that's possibly because each unit increase in what they call dose steps, or each dose step increase of one is only 0.036 milligrams of liraglutide. Now, I've got an interesting patient here with Ahmed, diabetes for 12 years, very fitness orientated, as many young Emirati men are. And he had a high BMI, but obviously in part that was because of his high lean mass, which Prof. Janet was also mentioning. Now, he was on MDI with CGM because obviously he sees himself as a bodybuilder, doesn't want anything adorning his handsome frame. His HbA1c, though, was suboptimal, and he was very frustrated about this. And he had self-initiated, actually. I say self-initiated. I think he was put up to it personally by his gym trainer. I just hope that's not all the only thing they were putting him up to. But I think his trainer in the gym had put him on this, or recommended to him this low-carb, high-protein diet, which he'd been doing for the last 2 months. And you can see it wasn't tremendously effective because his A1C is 7.8. So he was on this very strict diet of less than 50 grams a day of carbohydrate, and he was doing intensive aerobic exercise 5 to 6 days a week, and self-adjusting insulin doses according to online resources, which is possibly a frail read to rely on. And he was very keen to lose his body fat, which he was monitoring closely with the gymnasium's body composition analyzer. And he'd done all this independently, and actually until the appointment, his parents had no idea that he was doing this. So there are risks from this approach. So one of them is that you have an increased risk of hypoglycemia unless you're adequately adjusting your insulin. Dyslipidemia is very common. I had some shockingly bad lipids very recently in a patient who was doing a low-carb diet, LDL of 180 and 4.5 millimoles, or 4.7 millimoles for those who are in millimole land. You're at risk of euglycemic diabetic ketoacidosis from reducing your insulin doses to the extent you have to when you're having such a low level of carbohydrates. And when you have a very unbalanced diet, obviously you're potentially micronutrient deficient and could be lacking in vitamins, minerals, and fiber. And there are potential concerns about long-term cardiovascular risk. And obviously, if he was growing at 16, he's probably not growing much. There would be an effect on growth. And I've seen a few families over the years, or quite a few families over the years, where they've gone on the low-carb diet at diagnosis to try and stave off the evil day when they have to start amping up the insulin. And the result is the child doesn't grow. So that is an issue. I mean, if you think about why do people on low-carb diets lose weight, it's because they're not eating as much calories. So if you're not eating the carbs, you have to make up the carbs by fat and protein, and that's not necessarily the diet that youngsters want. So you need carbs for your brain. I don't know how he did in his math exam. And in girls, obviously, it can cause menstrual irregularities, and there is the potential of neurocognitive impairment. But on the other hand, studies in adults on low-carb diets have shown that they do rather well. So it can be a very effective strategy, but you have to do it in the right way. So how do we do it? Well, I'll come to that. Actually, we just need to think about whether this is potentially engendering an eating disorder, and is this a reaction to his diabetes, distress, and burnout? Is there family conflict over dietary choices that perhaps is part of this? And obviously, it's somewhat socially isolating if he's having a very different diet to what his friends are having or his family is having. And the obsessive focus on food and weight is perhaps not so helpful. And he, I think, felt he couldn't easily tell the healthcare team, which is why I think he did it on his own. But on the other hand, actually, I don't mind what people do as long as they tell me, and I'll try and help them. So unsupervised low-carb diets really can potentially cause multiple or can pose significant problems across multiple domains, and you need some nutritional input here and possibly psychological support to do this safely, as well as the ongoing medical supervision. So the medical supervision takes the form of the multidisciplinary team. You need collaborative decision making with the patient and the family. This is a shared thing, a shared risk, I suppose, between him and us, and monitor for the signs, indications of disordered eating. Obviously, we want to continuously monitor his glucose, as all people on intensive insulin therapy should be, and also daily ketone monitoring. So this is a bit burdensome, but on the other hand, it's to keep him safe and avoid diabetic ketoacidosis. And obviously, we're going to monitor his HbA1c and lipids and track hypoglycemia and growth if that's relevant, and involve a dietitian. So a pediatric dietitian specializing in pediatric diabetes, with individualized meal planning if necessary to ensure adequate nutrition. Now, that's a lot of work for the dietitian, and he probably needs some micronutrient supplements in addition to his unbalanced macronutrient intake. And ideally, we need to liberalize his carbs a bit. So 50 grams, or 30 to 50 grams, as is pretty commonly used, is a bit too low, I would say, if you have diabetes. And we need to re-educate him on sick day rules, what to do when he's ill, because then he shouldn't be so stingy with the carbs at that time. We need to make sure his carb ratios are right and his correction factors are right, and educate him about the management of exercise with reduced carbs. So he had liberalization of his carb intake, which actually made him feel much better and more energetic. And we gave him an insulin adjustment plan that worked for him. And he had a structured program with the gym of aerobic and resistance training. So the resistance training is actually very beneficial for insulin resistance. And a monitoring protocol. So initially it was weekly check-ins for the first month, and then bi-weekly with growth and metabolic monitoring. So how did he do? Well, he did all right. His baseline BMI was 27, it fell to 24. His HbA1c improved, and his total daily insulin dose improved also. He wasn't having significant hypoglycemia despite being a gym rat. And so all in all, I think that was a successful outcome from an unpromising starting point. So if we think about tackling insulin resistance in type 1 diabetes, there are various things we can do, such as optimizing the insulin, checking the injection sites technique, timing and dosing is important in this situation. Sometimes you find, oh my goodness, what a large lipohypertrophic site you have there where you're injecting, and that's obviously not going to help the situation. Lifestyle modification is good in principle, but rarely sustained. Metformin is recommended, but I think what I would say is if it's not working, stop it. It's not going to endure anyway. Going to type 2 diabetes for a moment, we know that metformin is not sustained in its benefits. And second line options such as GLP-1 analogs and SGLT2 inhibitors may well be a better choice. And in certain situations, you might use a combination. So you're using the SGLT2 and the GLP-1. Going back to Layla, our patient on the pump who was having Ideglira, then actually it would be reasonable in her to add an SGLT2 inhibitor if she needed more than we were giving her with just the Ideglira alone. So in terms of comparative efficacy, then you can see that metformin has really a rather modest effect, whereas the other options have really much better effects, but also come at the cost of significant side effects. So I think that dapagliflozin should be something that we're using more, and semaglutide, which is already approved for weight in those aged over 12.
Apologies, Janet, just exceeding the time for the presentation.
Okay, I'm just at the end. So in that case, let me move off this slide. So in conclusion, insulin resistance is a common problem. Insulin optimization and lifestyle can help. Low-carb diets could be an option in some selected cases, but you have to do it carefully with dietetic support. Metformin is commonly regarded as first line, but in practice, the response is not durable, and it maybe isn't the best first-line choice. SGLT2 inhibitors, or SGLT inhibitors, if we include sotagliflozin, and GLP-1 analogs are effective, and combination therapies may be required in specific situations, but these treatments come with risks as well as benefits. So thank you for your attention, ladies and gentlemen, and apologies for overrunning.
Thank you, Dr. Nando, for your great presentation. And we will be moving to the last presentation of this webinar, which will be presented by Professor Janet. And it's about how to reduce the cardiovascular complication in type 1 diabetes. Please proceed, Dr. Janet.
Yes, thank you. Let me go ahead and share. Okay, so I will try to cover this topic in 20 minutes. It's quite a big topic, but cardiovascular disease in diabetes is increased both in type 2 and type 1 compared to people without diabetes. And coronary artery disease occurs earlier in life. It's typically more diffuse, affecting more vessels, and it's more often fatal in people with diabetes. CVD risk is also increased by diabetes to a greater extent in women than in men. And this leads to a life expectancy loss of about 11 years in men and about 12 years in women. So what are the mechanisms contributing to cardiovascular disease in type 1 diabetes? Well, it's very complicated. Certainly, hypoglycemia can contribute, as well as glycemic variability and hyperglycemia. As we've already talked about, insulin resistance contributes. There can also be lipid disorders and dysfunctional immune responses that can contribute to vascular inflammation. And also, there are microvascular complications, including diabetic nephropathy, that contribute as well to cardiovascular disease. And cardiac autonomic neuropathy also contributes. And then there are the usual CV risk factors: tobacco smoking, elevated LDL cholesterol, and hypertension. So the traditional treatment to prevent cardiovascular disease in type 1 diabetes is targeting the ABCs, or hemoglobin A1C, blood pressure, and cholesterol. So improving A1C has been shown to decrease the risk of a cardiovascular event. So shown here are data from the cardiovascular outcomes update at 30 years after the Diabetes Control and Complications Trial and Epidemiology of Diabetes Interventions and Complications follow-up study. So intensive insulin treatment compared to conventional treatment reduced the risk of a primary composite cardiovascular outcome by 42% and the risk of a major cardiovascular event by 57%. So certainly A1C contributes to cardiovascular risk, and that's one way to prevent it. We also, in the cacti cohort, found that both hemoglobin A1C as well as time varying and standard deviation of hemoglobin A1C contributed to cardiovascular events. So having those kind of variations in your hemoglobin A1C over time, as well as mean A1C, contribute. But there are limitations to hemoglobin A1C reduction as a strategy to reduce cardiovascular disease. So shown here from a study published by Lind et al., you can see that even in people with very good glycemic control, meeting glycemic targets, there was a threefold increased risk of death from cardiovascular disease in people with diabetes compared to people in the general population. So just improving glycemic control isn't sufficient to reduce the risk associated with diabetes. And most of the prediction equations for predicting cardiovascular risk have not worked as well in people with type 1 diabetes, and some of them don't even go below age 40, and so can be very, very difficult to implement. So more recently, there was a new model developed called the Life T1D model, and they found that the predictors of cardiovascular disease included younger age at onset, hemoglobin A1C, traditional risk factors including smoking, body mass index, blood pressure, and non-HDL cholesterol, and then also renal complications, so estimated GFR and albuminuria. So certainly treating blood pressure and lipids can be effective. So treating a systolic blood pressure of 140 and getting it down to 130 was associated with about a 20% reduction in cardiovascular risk. Similarly, treating an elevated LDL cholesterol was associated with about a 20% reduced risk of a 10-year cardiovascular event. As I have mentioned in our previous studies, we have found that lipids are actually not elevated in people with type 1 diabetes. In fact, they're a little bit better. And hypertension is a little bit increased, but not by a very large amount. And body mass index tends to be similar, although there's been increasing obesity in more recent years in people with type 1 diabetes. So despite really not huge differences in some of the traditional risk factors, there is a very large increase in the prevalence of subclinical atherosclerosis as measured by coronary artery calcium. So certainly reducing those risk factors is important, but just reducing hemoglobin A1C as well as blood pressure and cholesterol doesn't seem to abolish all of the additional risk. So we did a study examining whether meeting the ABC goals, so in other words, meeting A1C targets as well as blood pressure and cholesterol targets, reduces the cardiovascular and microvascular complications of type 1 diabetes in the cacti study cohort. So what we found was that there was a very strong relationship between meeting all or some of the ABC goals with microvascular complications, but less of an association with coronary artery calcium or subclinical atherosclerosis. And further, only 6% of participants in our study met all of the goals. So it's very difficult for people with type 1 diabetes to meet all of these goals. And so perhaps additional help is needed in terms of improving cardiovascular risk. So What we found was that the predictors of a first cardiovascular event in the cacti study included hemoglobin A1C, so not surprisingly. It also included insulin dose. So we talked about people being able to reduce their insulin dose in the previous talk, and does that impact cardiovascular risk? And it seems to. Increasing risk was associated with a higher BMI, higher cholesterol and LDL cholesterol, and a higher systolic blood pressure. There was also an association with estimated glomerular filtration rate, so again, kidney function, and also with our estimated insulin sensitivity equation that I told you about in the previous talk. So having a higher estimated insulin sensitivity was associated with a much lower risk of a first cardiovascular event. So when we looked at independent predictors of a first cardiovascular event, including all of the risk factors in a single model, these were the risk factors that were included in a backward selection model: estimated insulin sensitivity as well as hemoglobin A1C, so showing that both insulin resistance and hyperglycemia are important, estimated GFR, so renal function, systolic blood pressure, and current smoking. So importantly, also age and sex didn't predict the first cardiovascular event, but diabetes duration did. So again, that goes back to the T1D Life model showing that earlier age of diagnosis is associated with a worse risk. So adding to the paradigm of the ABCs and targeting hemoglobin A1C, blood pressure, and cholesterol for control, additional factors that need to be considered include smoking, obesity, insulin resistance, and renal disease. And recently, the American Heart Association came up with the cardiovascular kidney metabolic syndrome. So that certainly seems to be in play in cardiovascular disease risk in type 1 diabetes. So there are novel agents that have been shown to reduce cardiovascular disease in other populations. So in particular, GLP-1 and GIP treatments. These treatments reduce hemoglobin A1C, as we've already discussed, but they also have significant effects on cardiovascular risk reduction beyond just the glycemic benefits. They also provide renal benefits to people without diabetes who have obesity. So could these be useful in type 1 diabetes? They reduce the risk of a cardiovascular event in people with type 2 diabetes by about 20%. And cardiovascular outcome trials for GLP-1s overall show a benefit. So how do they reduce cardiovascular risk? So they improve glycemic control, cause less glycemic variability. They cause weight loss and improve lipids, as we've heard. But there are also direct effects through the GLP-1 receptor, including shifting inflammatory patterns, suppressing foam cell formation, et cetera, that could reduce the risk of a cardiovascular event. So we conducted a study of semaglutide in type 1 diabetes. Here in the US at 4 different sites. We included 72 obese adults with type 1 diabetes randomized to semaglutide or placebo. The treatment was for 26 weeks, and all of our participants were on an automated insulin delivery device, so using the gold standard treatment already, but still were not at goal. The primary composite outcome of the study was weight loss achievement of at least 5%, with glucose time in range of at least 70%, and glucose time below range less than 4%. And we also looked at arterial stiffness, lipids, and blood pressure, as well as some MRI studies to examine changes in cardiac structure and function. So shown here are the baseline characteristics. So we had 36 control participants and 36 semaglutide. They were very similar in terms of baseline characteristics, as shown here. We have published the primary study results in New England Journal of Medicine Evidence last year, and 36% of the semaglutide treated group met the composite outcome, and none of the placebo group achieved that outcome. So shown here, we also saw a significant change in hemoglobin A1C from randomization in the semaglutide group, as well as improvement in time in range. So as you've already heard, it's effective at modestly improving glycemic control. We saw significant weight loss and change in BMI in the semaglutide group with about a 9% weight loss overall. And that was about 9.2 kilograms. So over the 26 weeks, we saw that a weight loss of at least 5% was achieved in about 75% of the semaglutide group. And further, almost half of them achieved a weight loss of at least 10%. And then, as you can see here, more of them met a time and range target of greater than 80% and an A1C less than 7%. So now turning to cardiovascular and renal markers, shown here are the baseline characteristics, again, by randomization group. There were no differences in blood pressure, lipids, or renal function. There was a significant improvement in total cholesterol, LDL cholesterol, with no difference in triglycerides from randomization. We did see a slight but significant change in HDL cholesterol after randomization that kind of resolved by 26 weeks in the semaglutide group. We also saw significant improvements in systolic blood pressure without a significant change in diastolic blood pressure. And in terms of renal parameters, there was no change in the estimated glomerular filtration rate, but the urinary albumin to creatinine ratio decreased significantly in the semaglutide treated group by 26 weeks. So then we examined the 5 and 10-year cardiovascular risk event using the Steno type 1 diabetes risk engine with semaglutide, and we saw that across the board, there was about a 15 to 16% reduction in the 5 and 10-year risk for a cardiovascular event with using semaglutide. So in summary, the participants randomized to semaglutide versus placebo were significantly more likely to meet our composite outcome, with over a third meeting the criteria, including, again, achieving at least a 5% weight loss, time in range greater than 70%, with time below range less than 4%. On average, our semaglutide treated group had a weight loss of about 9%. They also saw improvement in glycemic metrics with an improvement in A1C of about 0.3%. And participants randomized to semaglutide were also able to reduce their insulin requirements by 30%. So that's in our published paper. So that's important because, as I showed you, insulin dose is associated with cardiovascular events. So we saw significant improvement in total and LDL cholesterol, systolic blood pressure, as well as renal function. And also, not shown here, but we measured arterial stiffness measured by brachial artery distensibility, and that was also significantly improved by semaglutide treatment. Oops, sorry, went backwards. So semaglutide was effective at achieving weight loss and improving glycemic metrics in obese adults with type 1 diabetes. Patients were also able to reduce their insulin requirements while also improving their glycemic control, and cardiovascular and renal markers were improved. So while weight loss was achieved over time with a significant time by treatment interaction, improvements in insulin requirements, glycemic control, and cardiovascular and renal markers occurred within the first 4 to 8 weeks of treatment and were sustained through to 6 months. So this suggests that those effects are independent of the weight loss. So in conclusion, cardiovascular disease remains a common and devastating complication of diabetes. Despite recent reductions in cardiovascular mortality overall, there's still more than a decade loss of life expectancy. Mechanisms related to hyperglycemia and insulin resistance, as well as traditional risk factors, contribute to cardiovascular disease. And some of the novel anti-diabetic medications, especially GLP and GIP agonists, reduce cardiovascular disease and may be as effective in people with type 1 diabetes as in type 2 diabetes, providing an important new tool in the arsenal for combating cardiovascular risk in this population. And again, just wanted to acknowledge co-authors, and thank you very much for allowing me to give this presentation.
For the presentation, we start going to the question and answer session now. So I really encourage you to put your questions in the question and answer box, please. And okay, so let me go. They have a question here. I believe it'll show like that. Can we use? Okay. We can use oral insulin and teplizumab for prevention of type 1 diabetes in children positive for one antibody. Shall we use it in children less than 10 years of age and then see the response? Kindly guide. I think this question is for Dr. Walid.
Yeah.
It's about.
Okay, so thank you for the question. All the data I have shown in my presentation were in a research field, and none has been translated into clinical practice except the use of teplizumab to delay type 1 diabetes in children age 8 and older. So to answer the question directly, no, we do not have the approval to use oral insulin in children less than 10 years or even older than 10 years until more data becomes available about the outcome and safety. But for your information, the studies I have shown included children as young as 4 months of age and then older, but nothing for clinical practice until more data becomes available.
Okay. And there is another question: could we use semaglutide in adolescent with obesity? Maybe Dr. Nandu, I think the question is basic for you. If you could address that question.
Yes, so the reason or the basis for our use of semaglutide in obese adolescents with type 1 diabetes was that it's already approved for obesity. So we weren't going off-label or venturing into unknown territory. We already have an approval, so we used it on that basis. And it's very effective, extremely effective. So I've had very good experiences with that. And obviously, Mounjaro has recently been evaluated in type 2 diabetes down to the age of 10 and shown to be highly effective, even more so than semaglutide. So I think that that will quite likely get a pediatric license for type 2 diabetes in the relatively near future, sometime next year.
Yeah. I think there was a question earlier about more than one of the attendees asked about the use of SGLT in type 1 diabetes. And if you could, Dr. Nado, if you could elaborate more about just the use of SGLT and the precautions need to be taken for patients who are already like type 1 diabetes and on SGLT.
Sure. So the SGLT2 inhibitors were approved for adults with type 1 diabetes until the company itself withdrew their I don't know what you withdraw exactly. You withdraw your license or whatever it is you do. But anyway, they asked for it to be unregistered or unapproved for type 1 diabetes. But it did used to be approved. And actually, I've had good results with those drugs over the last few years. And but you have to do it safely. You have to choose a reliable, trustworthy patient. It's no use giving it to the child or adolescent with recurrent DKA. That's a recipe for disaster. And I think at least at the beginning, you need to be doing a ketone monitoring. And ideally, in the very first week or so, on a daily basis. Now, you need really to use blood ketones, and the blood ketone strips are very hard to get now. And I mentioned the continuous ketone, glucose and ketone sensor that's coming from Abbott, hopefully next year. And that could be the answer to our dreams when it comes to considering the use of insulin-sparing therapies, because, potentially, even GLP-1 analogs could be associated with ketosis if it suppresses your insulin dose sufficiently. And so to have these better options or these optimal options for the patient, I think would be great. But we need to do it safely. So that means ketone monitoring. It means stopping the SGLT2 during illness or dehydration for any reason, and being sensible. So I think you have to choose sensible patients. I think there's no use going for the train wreck patient with type 1 diabetes and recurrent DKA. That would be a disaster. So yes, I would use them, and I do use them.
Yeah, thank you. Professor Janet, there was a question, I think, in one of the chat box about the reliability of the insulin in pediatric patients. How reliable is it? And the other one was about what's the strict blood glucose control importance in cardiac patients after a heart attack or a significant cardiovascular event?
Yes, thank you. So what was the first question?
About the reliability of the insulin resistant or home IR testing in pediatric patients.
Oh, right. Yeah, so we don't typically use the HOMA IR just because it was developed in people without type 1 diabetes, and since it's using insulin and glucose levels, they can be affected, obviously, by treatment in people with type 1 diabetes. So it is not typically as reliable. Um, and I think I saw a question about the clinical utility of
Yeah.
the insulin sensitivity equation, or the insulin resistance test. There isn't currently, unfortunately, there isn't currently a really good method for estimating. You can estimate insulin resistance, but there isn't a cutoff that's determined to be abnormal in people with type 1 diabetes. So I think that's an area that we're working on, trying to figure out how much of a role insulin resistance plays in cardiovascular disease and if there's a particular level that's associated with increased risk. And as far as the question regarding glycemic control after a heart attack, both hyper and hypoglycemia after a heart attack can be detrimental. So it's important to maintain good glycemic control because of the risks posed with somebody who already has, very significant atherosclerosis and an unstable um, cardiovascular situation.
Okay. Professor Janet, I had a question myself about the for the glucose variability. You mentioned about the HbA1c variability and the risk of insulin resistance. So, but what about the glucose variability? We often look at it when we see our CGM reports. So, how that could affect your cardiovascular risk, the blood sugar variability, not the HbA1c.
Yeah, so I think there's kind of two aspects of glycemic variability that both could impact cardiovascular risk, and one is sort of the lifetime glycemic variability. So during adolescence, people tend to have a much more difficult time maintaining glycemic control, partly due to the insulin resistance related to puberty, and just the difficulty of managing type 1 diabetes, a chronic disease as an adolescent. So that can cause metabolic memory. So despite having improved glycemic control, it's been shown that having a period of really poor control can contribute to cardiovascular disease risk down the road. And we're not entirely clear on what those mechanisms are, but then also having more glycemic variability currently is also associated with worse cardiovascular risk, probably because having periods of extended hyperglycemia or extended hypoglycemia um, can cause, can induce inflammation and various things that can increase the risk. So I think both are important.
I've seen the slides about the cardioprotective effect of the GLP-1 or the cardiometabolic outcome in type 1 diabetes. You think that it will soon be a standard of care in these patients?
I think it's very promising. I think because it targets so many of the cardiovascular risk factors all at once. I think that there are ongoing studies that will help kind of prove the efficacy and hopefully will lead to making it more available for people with type 1 diabetes. I think currently the cost is an issue, and so I know a lot of people have trouble getting insurance coverage for it currently. Um, but I'm hopeful that it will become standard of care as people with type 2 diabetes can access GLP-1s, and whether it's improving glycemic control, it's a more modest improvement. So that's a little bit more difficult in terms of proving the efficacy for use in type 1 diabetes. But in terms of improving cardiovascular risk, I think that may be one of the really important drivers for hopefully making it standard of care.
Yeah. Just looking at the question, Dr. Walid, I have a question about, you mentioned about the oral insulin in the primary prevention. I just was wondering in that study, so those patients were, they didn't have any higher risk of hypoglycemia, those who use the oral insulin, and the second one for the use of teplizumab in patients who are established type 1 diabetes. So about the prevention of, or the current use of teplizumab to delay the onset of the stage 3, but how long, or what was the uh, how long it prevented the or the reduced the insulin intake in patients who are established type 1 diabetes?
Okay, so the first question, when insulin is taken orally, it is degraded in the stomach. So basically, it will not have the hypoglycemic effects on the glucose metabolism, but it still work for the immunogenicity benefits. So it was started from the earlier stages of using oral insulin. They've already confirmed that there was no issues related to this, and it was considered as a safe way of using it for the immune benefit purposes. The second question, the teplizumab did not actually reduce the dose of insulin, as I showed that the only benefit in newly diagnosed type 1 diabetes patient was the C-peptide area under the curve on week 78, the end of the study. But the average dose of insulin to maintain glucose at target was unfortunately not different between the two groups. Neither was the percentage of time glucose was in range or HbA1c. So some benefit, probably the hope was that we'll see more positive outcome, but that's what the study showed.
And Dr. Fernando, if you want to, like, about the adjuvant treatment of type 1, of insulin-resistant type 1 diabetes, well, you have mentioned like 4 different modalities of in the cases you presented. If you want to summarize if I have a, like, when I will be starting thinking about the using of adjuvant therapy in type 1 diabetes, and if I have all the options available, which will be I'll starting with?
Well, it would depend on the patient, of course. So if you've got a patient whose issue is obesity and inexorable weight gain, then a GLP-1 would be the best option. If you've got someone who's insulin resistant but not so obese, or at least not to the same degree, then an SGLT2 inhibitor would be a reasonable alternative, but equally using a low dose GLP-1 is probably better. So I think, and obviously it depends on other factors like, how prepared is the young person to have an extra injection, or how do they feel about the potential risk of ketoacidosis? So, you've got these other things to consider. Are they reliable? Can you trust them? If they're on an SGLT2 inhibitor, you definitely don't want to do that in an unreliable patient. You don't want to hospitalize them with a life-threatening condition. So low-carb diets, they do have a role in adults. And there are even young people, even young children who are on low-carb diets, and it can be done successfully. But you really need to be absolutely scrupulous with your attention to the diet. So I don't recommend that generally. Lower carb diets, I think, is a reasonable approach. And even doing simple things like going for a short walk postprandially increases your insulin-independent glucose uptake by muscle. So that's glucose you don't need insulin for. So that's a very simple way to improve insulin resistance. And exercise generally is a very good approach. So I think you can address the issues. It really depends how extreme they are. There's always going to be situations when you don't really have any good options. I think, but for most people, you can help them.
Yeah. Well, I think there's no more questions. So I really would like to thank all the speakers for the great presentations, and thanks the ADA members for this great collaborations, and looking forward collaborations in the near future. I would just like to mention that there will be some announcement, if you can allow me to go through them. So this is a few activities coming by the EDES. So this is the Create a Learning initiative by the EDES and the Sharjah University. There will be an upcoming webinar on Thursday. This is another CME accredited course about modern approach to obesity, which will be on Wednesday, the 26th of November. The barcode is there, and then the another one about the ethics in action for clinical trials, again with collaboration with EDS and the Sharjah University. Now the link for registration will be sent to you through your in the chat box. You will be also receiving emails about these activities and how to register them. We also encourage you to have the membership with the ADA professional member platform, and there is a join today, and there is a 10% discount as well. There's also about Immerse Diabetes and Endocrine Society in collaboration with the ADA. It's a course about making diabetes technology work continuing education program. This is as well as a CME accredited program by Dubai Health Authority. And this is here is the registration link and the barcode to register, and you will be receiving the same. You can see them in your chat boxes as well. And finally, I would really invite you all to participate and register for our annual Immerse Diabetes and Endocrine Congress, the 2026. This is the 16th year in a row, and it will be held early next year between 6 to 8 February 2026 at the Dubai International Convention Center exhibition in Dubai. So we're looking forward to meet you all there in person. Thank you. And thanks again for all our attendees, and thanks for all our participants. Thanks for speakers. And again, thank you for the EDS and ADA for this great collaboration. Thank you.